I'd like to welcome you all and thank you for joining us for today's webinar hosted by the NIH-funded MD2K Center of Excellence at the University of Memphis. My name is Brian Ahern. I'm the training specialist here at MD2K in Memphis, and I'd like to say we are very excited about today's presentation titled Moving Beyond User-Centered Design to Improve Population Health. This webinar will focus on digital mental health and user engagement, discussing the intersection of user-centered design and community-engaged research in intervention development. So this will include discussing the roles of peer support specialists in digital health and taking a deep look at Peer Tech, which is a peer and technology-supported self-management intervention system. And we are very lucky today to have our presenter who has been working very hard on developing this system, Dr. Karen Fortuna, who is Assistant Professor of Psychiatry at Dartmouth College. Karen's primary research interest is service delivery strategies for adults with serious mental illnesses and chronic health conditions. And we're also very delighted that Karen has brought on a special guest presenter to join her today, Mr. Robert Walker, who works for the Massachusetts Department of Mental Health Office and Mental Health Office of Recovery and Empowerment. Robert has, among other things, led efforts to develop peer-enhanced emergency services and has been co-designing the Peer Tech system with Dr. Fortuna. So with that, I will hand it over to our presenters. Karen, Robert, if you're ready, the floor is yours.
Hi, everyone. Thank you so much for having us here today. Hi, everyone. Thank you so much for having us here today. Rob and I have been working on a really interesting program of research where we've been developing and implementing peer-delivered and technology management interventions for adults with serious mental illness. And we combined an approach of user-centered design with community-engaged research in an effort to develop a program that's more feasible, acceptable, and more relevant for the real world. So just some quick definitions. So when I refer to a peer, I'm referring to a person who has a lived experience of a mental health condition. We specifically work with certified peer specialists who are trained and accredited by their respective state to provide peer support services. And peers have traditionally augmented traditional psychiatric care. So peers generally provide care in the community and not so much in a clinical setting. So peer support has been Medicaid reimbursable since 2001, and it has shown to decrease hospitalizations, decrease symptoms, promote hope, empowerment, and quality of life among people with serious mental illness. So this program of research really came about from a health disparity in which people with serious mental illness, they die up to 32 years earlier than the general population. And we've known this as scientists for decades. And there's been billions of dollars spent and national campaigns that have attempted to address this health disparity. And what we have found, despite all of these dollars spent and amazing interventions developed, people with serious mental illness, they're actually dying younger than ever before. So Rob and I were talking about developing a new paradigm where we can integrate user-centered design with community-engaged research to promote large-scale dissemination and population health. So if you have any questions as I move forward, please feel free to ask. So I do not have any disclosures. I do have grant support from a K01 award and a NARSAD Young Investigator grant. So for today, I'm going to talk about the law of attrition in digital mental health. And this is a term coined by Gunther Eisenbach. We're going to talk about this as related to research and population health. Then I'm going to talk about some solutions that we have to attrition in digital mental health that the scientific community have developed and worked towards, including user-centered design, community engagement, And then I'm going to talk about this integration of the approach. And then Rob and I will speak to where we've developed this program called Peer Tech using this innovative approach. So to begin, the law of attrition, again, this is a term coined by Gunther Eisenbach, and we still experience it today, that the fundamental challenge in conducting mental health research is participant disengagement. And we know that individuals will disengage generally after the first 2 weeks in our scientific studies. And industry has experienced this as well. So for example, the Pokemon Go program, which is an app-based program which was designed on the premise that you can incentivize the users if they go around and acquire virtual goods at different physical locations such as Pokemon stops or gyms. And with this, there was a massive uptake of this. Like within the first week, there was 45 million users. And then after 1 month, this actually dropped by 66%. So it's down to 15 million users. So in science and also in industry, we're still experiencing this disengagement problem. Within healthcare, and when we conduct our studies, that also leads to additional problems. Of course, if people drop off, there's going to be a loss of an intervention effect. Also, if people drop off, they create a bias too, as in that the individuals who drop off or stay on for the duration of this study, they're fundamentally different than the other individuals that stay on the study. Again, this reduces our data quality, and it could relate to high rates of data missingness. And of course, there's lack of transparency in our study design, where if people drop off, we don't know, it's not clear how many people dropped off, how they engaged, or at what time point if they left and came back, all of which can lead us as scientists to inaccurate conclusions related to the strength and directions of association. And how that impacts population health is that if we come up with these inaccurate conclusions and then disseminate this widely, it could have a negative impact on population health. So of course, maximizing engagement is really important. So some colleagues of mine developed a consensus around developing smartphone apps and digital mental health. And so this was published in World Psychiatry. And here we have industry leaders and also scientists coming together to develop this consensus. And they suggest the issue with disengagement, that we can address this by including end users in the development and design of the technology projects that we create. And this is designed, this is user-centered design, in which we attempt to increase the usefulness and satisfaction with technology, and all of which will increase engagement as well. There's lots of different techniques to employ user-centered design, some of which we'll talk about a little bit later, but they can be the think aloud approach in clinical environments, field usability tests, and also people use design thinking to promote user-centered design in our products we're developing. Now, when the field developed, they were creating VCRs, cameras, and flip phones. They weren't creating smartphone application wearables where there's artificial intelligence in them doing data analytics for us. They weren't doing active and passive monitoring within our systems. And there weren't any avatars being developed and integrating treatment from one avatar to another individual. And of course, there was no virtual worlds. So the field of technology has really advanced, but while user-centered design, when it developed, they were working on earlier types of technology related to VCRs and cameras. So with user-centered design, most digital health development processes, they actually don't include user-centered design. And when they do, they include them in small trials in a very clinical environment. So what they'll do is they'll have an individual come to a location and they'll sit with them in the same room and ask them questions about an app or some type of technology as they're using it. And this is all as the scientist or the research assistant is collecting data on their actual use of it. Now, when the person leaves this clinical environment and goes out into the real world, there's lots of different other contexts and environments that the person will interact with. And we don't know how someone will interact with their phone outside of this clinical environment. Also, too, user-centered design may not be capturing the full potential of individuals. So again, here's the Pokemon Go program, and this is a picture of something on Twitter that was posted after the large uptake of people downloading the app. And you see the hashtag on there called MyPokeHood. And here, what was happening was, despite this app game, which was incentivizing users to go and acquire virtual goods, these virtual goods and locations actually weren't in racially and ethnic minority, low-income urban areas. Rather, these virtual incentives were more in white demographic areas, and so people were suggesting that this was my Pokehood. So what happened is that the Pokemon Go app developers, they actually relied on maps from one of its prior apps, and these were crowdsourced by a majority white male demographic in commercial areas. So they did not include the voice of all end users, in all of which can lead to unintentional consequences of potentially perpetuating health and healthcare disparities for unresourced populations. And two, when this app, My Pokemon Go, came out, there was a lot of excitement among the scientific community suggesting that maybe this is a way to promote physical exercise. And then with a large drop-off of individuals and then the My Pokehood, I think people had moved on from this approach and were looking to other types of things where it didn't have the potential for perpetuating health and healthcare disparities. So here's user-centered design. It's a figure of this, and so we see on the left-hand side that when we're designing our research studies using this approach, the researchers and other stakeholders actually define what the problem is. It doesn't include the intended end users, and so this could be a person with a lived experience of a mental health condition. So the scientists are saying what the problem is that the intended end users are experiencing. Again, the study design is similar in its approach, where the other stakeholders and researchers determine what their study design will be. And as they develop whatever type of technology, that's really based on the researcher's opinion, and of course, scientific evidence to suggest what should be included in it, but it includes limited involvement with the needs and the development of both stakeholders and the intended end users. And I think this approach, the data collection, is what we're very familiar with. When we go out and collect data as researchers, we collect it with the intended end users, and so they're really involved at that point. Data analysis is really left up to the researchers and some with the stakeholders. So at that point, when we interpret data that we collect from the end users, the entire decision on what the findings are based up to the scientist. And then in the results and dissemination, researchers will have a large role in dissemination, potentially published in peer-reviewed journals, and then intended end users and stakeholders may have limited involvement in this approach and may not even publish with them in articles. So we recently completed a systematic review of digital peer support interventions, and we found that there were 30 studies available on 24 different interventions. And we collected data, then we categorized the approach that the researchers use to develop these peer-supported digital health interventions. And we found that user-centered design in combination with an active community engagement approach actually led to engagement compared to the projects that employed only user-centered design or only community engagement consultative methods. And so when I refer to consultative methods in community engagement, I'm referring to programs or methods such as conducting a focus group or conducting an interview and collecting data from a participant but then leaving it up to the scientist to interpret the data and to write up the results. That's more of a consultative approach. The community engagement approach is more that the end user has full decision-making authority within the problem definition, study design, the developing, understanding the research results, and also dissemination as well. So this could be referred to community engaged research, or it could be referred to community participatory based research. So if we look at the two of these in comparison to each other, so on the top here we have this community-based participatory research, and we define this as active community engagement. We see that community members, stakeholders, and researchers are involved in the entire process together, related to problem definition, study design, needs and development, data collection, data analysis, and research and dissemination. And we compare that to user-centered design, where we're not really including the intended end users and stakeholders as much as we potentially could. So Rob and I were talking, and we're like, well, what happens if you combine these two approaches? And we learned that it really fundamentally alters how the technologies are designed and implemented and translated into the real world. And by doing so, potentially produces a better technology that's more feasible, more acceptable among the community, and could also lead to higher levels of engagement as well. So looking at these side by side, the question is, why is this such an innovative idea? Why aren't we already doing this if it leads to better feasibility, acceptability, and potential effectiveness and larger reach? Well, both of these approaches do cost extra time, also cost extra resources, potentially, and all of which can cost additional money as well. And both approaches, you do need some highly skilled training in order to do them. So now we're going to talk about our case study, which is peer tech, is where we worked with peer support specialists, and through user-centered design and community engagement, we developed a smartphone-based peer-delivered intervention called peer tech. So once again, just to set the stage, so we know that people with serious mental illness, they die up to 32 years earlier than the general population. And we know that this is related to high rates of morbidity, medical comorbidity among individuals. So we wanted to see, well, because we know that mental health and physical health need to be managed at the same time in order to produce good effects, we wanted to take a look at integrated general medical and psychiatric self-management programs for adults. And so these self-management programs focus on promoting individuals' own management of both medical and psychiatric illness at the same time. So we completed this systematic review, and we found 15 studies out there that reported on 9 different integrated self-management interventions. And these interventions were feasible, acceptable, with really high potential for clinical effectiveness. So we wonder, why were people with serious mental illness still dying early, and actually they're dying younger than they were years before? So we looked at some implementation factors. We looked at both barriers and facilitators to implementation. Some of the barriers were in these interventions was the time to actually implement this intervention. And so some of them are up to 2 years long. And getting a person with a lived experience or anyone to come to the same place for 2 years is really, really intensive. And it does require a lot of time of the individual, and of course time of the service provider as well. This is also going to cost resources, including money and space as well. And so then we looked at some facilitators to implementation, and we found that some programs were working with peers in providing some of the programs. And again, peers are individuals who are trained and accredited by the state to provide peer support services. And we also saw technology too. people were able to reach a larger audience of individuals using certain type of technology programs. And so we thought about combining the two, and it led us to an entire program of research where we picked one of those interventions, and at this point, this is the scientific community decided to pick one of those interventions called Integrated Illness Management Recovery. And we chose this intervention because it had a high likelihood of real-world effectiveness. This original intervention was 10 to 12 months long, delivered by a master's level clinician. And in 2 randomized control trials, it showed that it increased medical self-management, psychiatric self-management, and also decreased hospitalizations in people with serious mental illness. And so at this point, we took this manual, this 200-page manual, and we translated this to be delivered over a smartphone application. And here, again, this is the scientific community. We used an adaptive systems engineering approach where we first completed a literature review and to find out what we need, what types of features do we need in this smartphone application. So we identified the need, which is on the left-hand side here, and then we identified a potential design feature. So, for example, in the real world environments, older adults commonly present with multi-morbidity, so they're going to present with multiple physical health conditions. And so we wanted whatever technology we were going to choose to be able to address multi-morbidity. Another one important is that individuals adopt and engage with health technology more if a human is part of the intervention. So we wanted access to live and or automated self-management support. Then we looked into some cognitive issues for this potential population and related to age-related memory loss and cognitive deficits could result in poor medication adherence. And then we wanted to include behavioral tailoring, so notifications related to medication management. So I won't go through all these in the interest of time, but we completed this literature review and how we were going to, what type of features we needed. Next, we selected the platform that we wanted to use, and we know that people with serious mental illness have smartphone applications, and we know that the digital divide between people with lived experience of a serious mental illness and the general population is actually decreasing, where we're seeing about 80% of people using smartphone applications, and so we decided a smartphone application. Next, we wanted to determine the architecture of the actual analysis, so we developed wireframes together as in just among a group of scientists together. And next, we did some user-centered design. So we did 2 usability tests. You see in cycle 1, we had an N of 5, and then we made a modification. And then cycle 2, we had another N of 5, and then made an additional modification. So in this approach, we had the smartphone application. We brought it to the end users using this user-centered design approach. And we combined the think aloud approach with the verbal probing, which means that if you give the end user a smartphone application, you prompt them to think aloud actually as they're going through the application. And from that, researchers write data and identify potential modifications in the application. We also use verbal probing because some individuals weren't familiar with technology applications, and so we had to ask them and encourage them to use the application. One of the quotes we found from this is that the nice thing about having the multiple size text is that if you wear glasses and you're crying and you want some support, you can use the app. So we use this very sophisticated user-centered design approach to create something that we thought would have really, really great potential to be delivered by peers using this smartphone application. But at this point, this is where the scientific researchers started to work with Rob Walker and his colleagues at the Department of Mental Health, and we brought them the smartphone application. And we said, look, we've created this great application that has the potential to decrease the early mortality risk factors among people with a lived experience of a serious mental illness. And we approached them, and they said, there's no way a peer is going to deliver this. And that's because we didn't include any of the values and principles related to an entire movement of peer support specialists that we really as scientists weren't aware of. And so this is a picture of someone holding up a sign saying nothing about us without us. And so this is related to the disabilities rights movement, which is when the scientific researchers started to begin to understand this, is that anything that was related to program development is that it should include the community as in every single part of the actual project. And thinking about this from a population health standpoint, if me and my colleagues had developed the app and then did some testing and people said it was great, if we actually tried to implement that into the real world, we would have been straight up in front of this sign once again, and the potential for dissemination would stop at that point. So here is what we had developed after that first meeting, and note this was this has been a development over the past 5 years, and so here's our community engaged research approach. So it went from the scientists using these sophisticated user-centered design approaches to actually working with the community and getting their input on the entire process. So at the top here, we see there's a gatekeeper that provides us access to the community. And without that, we probably would not have made it so far as far as we are with the program PeerTech. On the left-hand side, we have a peer research support team that we work with as equal partners, where there's shared decision-making. We both learn from each other, and we're both co-owners of all of the projects that we develop. And so they feed forward their expertise. And then on the right-hand side, we have this core investigator team, and we bring forth the scientific methods in order to create a product that we think will be usable. And of course, in the middle, there's this full partnership. So as we move forward from this point on, we start combining user-centered design with community-engaged research. And in that, my colleagues as equal partners in planning the study related to intervention development. They've assisted us in developing research questions, determining outcomes, where I'll talk about later, but we actually learned that there's other types of outcomes out there that are less medicalized, yet equally important. And then, of course, implementation considerations. They've also helped us with recruitment and retention in our studies, in which we've had pretty great recruitment and retention. And they've helped us develop some of the qualitative interview guides that we've done as well. And then dissemination, which I'll show you our website that we've developed together. We do a lot of social media posts, blogs, newsletters, and we present at lots of different partnerships. And of course, everybody works on developing relationships in order to move the research forward. So what came from that was this entire program of research where we're using that community engaged model. So first, we conduct a national survey of certified peer specialists' ownership and use of technology. And we find that the majority of people, 95% of certified peer specialists, you can see that at the bottom, had a smartphone, which was actually at that time considerably higher than people who are non-peers yet had a lived experience of a serious mental illness. We also asked peers if they were willing to use smartphones to promote health behavior change with service users, and we found the majority were really willing to do so. And also peers were willing to users to also promote population health. And now we then assessed the unmet needs of peers, and here is where we start to develop the content of the program. And we collected data from 267 certified peer specialists from 38 different states using an online survey. And we asked them what are your unmet needs? What do you want us to work with you to address? And so here's where there's problem definition. So we find the #1 need among individuals is loneliness, The number 2 need is social isolation. And the number 3 is this addressing comorbid physical health and mental health conditions. And so we take this information and we bring it to the table to enhance our intervention, our program. Finally, we also look at some implementation issues. Understanding implementation barriers and facilitators and early intervention development is really important how people move forward with programs and population health. So we find that peer support is a human factor to promote engagement. So we know people engage with smartphones more if there's a human attached to whatever program that is. And we asked, well, what about a clinician? And people were actually more willing and open to a peer support specialist as someone to engage with. Then also we found too, which was interesting, that smartphone interventions, there was a emerging theme related to it may promote social isolation. So if you develop smartphone-based interventions, this might make it so people aren't out there in the community engaging with other individuals. So this was definitely a concern among the group. So from that point, we went back to development and we revamped the smartphone application. And here, my colleagues played a role in developing the content. We had changed the language to make it a more acceptable language for individuals, because some of the terms we were using before were very medicalized, and this group many have rejected medicalized terms when it comes to dealing or working through mental health conditions. And so we recruited language that was more recovery focused and more open and acceptable to the community. For example, number 7 here, that used to be social skills training, which is an intervention that has been developed and has been proven to be, very effective for individuals to develop social skills. But we rewrote this so it's building relationships. It's a less scientific term, yet it means a similar thing. Also, we included self-determination in the peer tech classes, in which service users could choose what types of goals that they wanted to address. And we think whatever goal they want to address is going to help with their mental health and physical health self-management. Also, we included topics of interest related to that unmet needs article we wrote related to addressing loneliness and social isolation. And then importantly, we included peer support, which is an informal level of social support, but has been shown to, again, decrease hospitalizations, decrease symptoms in individuals. And this is something the peer support specialists wanted. They didn't want a program where they had to read from a binder to keep fidelity to the program. They still wanted to be able to provide their expertise in having a serious mental illness, because that's one of the things that they provide as their expertise. And some practical things. Our team helped us with hiring and how to train peers in technology, helped tremendously with recruitment and selecting the ideal sites. And then the research questions too I spoke about. And so my colleagues have helped us identify recovery outcomes related to hope and empowerment. And we see these now as mechanisms of action on these early mortality risk factors in individuals. And so we've done some studies on that related to how hope impacts your level of self-management skill development. And we're seeing that the two are interrelated, which is really exciting. So let me just give you a quick rundown of what we have developed here. And then Rob will be speaking soon. And so here's the program, Peer Tech, that we developed. In the center, we'll say that's Tom, and he's working with Sarah. Sarah is the peer support specialist. Tom is the service user. Together, they meet one-on-one for an hour, and they go through one of those each modules over a 12-week time period. When they're not together, Sarah is text messaging Tom and vice versa on how they're doing, following up on their goals and providing peer support through text messaging. And then Tom has some goals that he needs to do for himself, such as that he's identified for himself, such as walking 5 minutes a day, taking medications, and then watching maybe videos and reading texts on self-management. So quickly, we did a small pre-post study, and we had a mean age of 68.8 years old. The range was 62.77. Majority of people had major depressive disorder, and all of the individuals had 2 or more chronic health conditions. So our results were that we found that there was a change in medical self-management, quality of life, hope, self-efficacy, social support, empowerment, and actually a statistically significant change in psychiatric self-management. And note too, this is a pre-post study, so we really here we're establishing feasibility and acceptability of the program, and we're very excited to see some statistically significant results related to psychiatric self-management. And this study has led to national funding from the National Institutes of Health and also the Brain and Behavior Foundation, where we're conducting 2 separate randomized control trials with a sample of 30 people, then also a sample of 40 people. So we'll continue to revamp the program. So the benefits that we have found is that, the content is really important to the community. If you want uptake among a product, whether it's intervention or a technology product, that the content has to be able to speak to the individual. It has to be important to them. It has to address their needs. We see that there's better engagement when we include peers as a human factor. So in that, when peers text message the service user, we see a rapid increase in actually the service user using the app, which is really exciting. We've had great recruitment and also amazing retention as well. And so this is from working with Mr. Rob Walker. He's able to help us work through our recruitment and retention strategies to keep people in our studies. All of which is higher potential for uptake in the real world. We're getting contacts from around the world about the program. Peers are hearing about it and people are really interested in it and they want to know, when is it going to be ready for the next steps? Another important area is empowerment of community partners. So, working with some may not have been listened to in the past, they may not have been valued. Maybe they're historically stigmatized and disenfranchised. And so we think there are potential bi-directional effects when working with community members as equal partners in our research. And then co-learning with partners, the colleagues I work with, have brought really great ideas and insights that I would never have thought of. For example, we didn't think that loneliness was the #1 unmet need. Even though a lot of research suggests that loneliness is 3 times as bad as smoking cigarettes related to mortality. We never would have thought that, and so we had to, talking with our community members, they were like, yeah, of course, like that's a major issue, and so it really brings some new ideas and insights to our research. And now I'm going to hand it over to Ron. There you go.
Thank you, Karen. My face really isn't that squished, but we've worked with people, and they really wanted to know what the magic is about this, and I think the magic is that really the folks at Dartmouth identified a problem first and then use technology as one of the ways to solve it, rather than we got iPhone, we need to develop an app, let's develop it and see how it fits in the world. That was really the problem first, and that in fact it is a technology that enhances personal contact rather than stifling it. That it's a way for us with a shortage of peer specialists in Massachusetts, it's a way to sort of extend. It's a peer specialist extender And I think another reason why it's so successful is I sort of divide the world of apps for mental health in sort of the passive or active monitoring apps, and then the support, education, and self-improvement apps. That this really wasn't, that people with a lived experience, including myself, have been monitored to death in all sorts of ways. But this really wasn't about monitoring where we're going, how much exercise I had, how many miles did I run. It was really about support, education, and training on how to do self-improvement. And the fact that the thing that amazed me the most was really people with lived experience, including myself, were really involved in all phases, that we helped design the study and what factors we really wanted to look at that needed to be looked at, that we helped with recruiting strategies, including identifying organizations in the state where they would be more adapted to this new technology, and helping planning the data gathering and the intervention design, sort of this, so what we wanted to measure, how we wanted to how successful recruiting efforts can be made, and then finally the dissemination of the results, like who needs to know, and if this app is usable and successful, how do we get it beyond the journals and into the hands of those of us with lived experience who could benefit from using it? So I think the partnership is amazing with this. I'll throw it back to you, Karen.
All right, great. And that's a great segue, I think, for we have written a lot in research journals, and then I could show you some of the other dissemination approaches we've used. So here, Rob and I and a few other colleagues, we wrote about, developing the research agenda for digital mental health care, and we talked about the importance of moving beyond user-centered design and working with the community in an effort to promote programs and interventions that can facilitate population health. And we also have another one out that we wrote with some amazing influencers who have been advocates in the disability rights movement, where we took digital mental health standards and we updated them with a recovery-focused guidelines. And with this will be out really soon. And with this, we talk about the importance of working, with community members as equal partners in an effort to promote population health. And this is our one method of dissemination. Here's another one. So we've designed a website together. This is our team. Here's the website address right here. And this is a collaborative. This is about us. We have some of our latest news, and here I'll go to our digital peer support section. I won't go to it, but we have blogs in here as well. It's not opening, sorry, but there's blogs that we have as well that are written by service users and written by scientists in collaboration, and we send these through Facebook and all sorts of peer-delivered programs out there in the world, and so we're getting a lot of great feedback on them, and we're also getting a lot of interest in our program. So dissemination has really taken on a whole new meaning, which is pretty exciting, and it's really different writing than scientific writing is. So in sum, Here's a model of, community engagement, and really talks about the process of, developing our research and then disseminating it to partners, and then really looking at these implementation factors related to uptake and implementation. So with research benefits, the benefits have just been amazing, where we're getting new research questions and new ideas that we have never thought of before, and they make so much sense. We have some really exciting dissemination that we do as well. Of course, publications and then presentations. Rob and I were invited to give a presentation at Harvard University later this month, which is really exciting. And we have this great social media strategy that we're using as well to reach a lot of people, not just scientists. And of course, the uptake benefits of this approach are, the new policy and practices for trainees, new research questions, and then really the contextualization of the research. As scientists, if we're developing programs that we think the community needs, but the community tells us, I don't need that, I don't want that, they're not going to use that. And so that's really how we're able to work with the community and, promote uptake. And then implementation benefits, of course, new program funding has been, amazing. We're able to update our program based on the input of other individuals. And we're seeing a lot of policies and practices and individuals coming to us, really interested in the program, and they want us to spread it. And so the overall impact is that we can get our interventions out there into the real world with a higher level of feasibility, acceptability, and effectiveness using these types of approaches. So just want to thank everyone for having us here today to hear about this innovative program of research, and we can open it up for questions now.
Yeah, thank you so much, Karen and Robert. That's really wonderful insights into the worlds of digital health and mental health. But yeah, as Karen said, let's open it up for discussion and questions from the audience. If you have a question, just please remember to unmute yourself using the microphone icon at the top of your screen or the mute button on your phone. And feel free to ask a question or pose an issue for Karen or Robert, and they'll be happy to answer.
Hello?
Hi.
Hi, this is Jackie.
Hi, Jackie.
Hi, I just wanted to thank you for this because I was not aware of, I'm a certified peer specialist, and I was not aware of what you were talking about. I'm part of a peersolution.com. I do groups online.
Oh, great.
And I'm already working with you. You probably are aware of me. And also have done research with Illinois, Chicago to, show peer support. But I just wanted to thank you for this because I did not know there was an app out there. And is it going to become available for your, is the research done that it's there? People can get the app.
Yeah, we're currently, we want to conduct these 2 other randomized control trials before we open the app to the public. And so and we want to assess its level of effectiveness before, we allow it to be out there in the world. So we can keep in touch, especially if you're with Peer Support Solutions. I know you're some of your colleagues over there. And we can keep in touch about, where peer tech can go and maybe be integrated with Peer Support Solutions. If you just shoot us an email, that'd be great.
Yes, thank you. I'm excited to pass that information on to my peers in the groups, the meetings that I do, and the one-on-ones that I do online, and like I said, through Peer Solutions. So yes, I'll definitely keep in touch. Thank you.
Oh, yes, please do. Great. Thank you. Any other questions out there?
Hi, Karen. This is Shahin from Memphis. First, thank you so much for this presentation. It was deeply illuminating, and hearing all of these kinds of different strategies in which you've engaged with research participants and people in this community, kind of community-based way is really just, it's very special, I think, to hear. Were there any special considerations from a human subjects protection standpoint that required consideration in engaging with this research, or any other kinds of ethical insights that you may have gathered?
I think that's a great question, and what we have generally done is that the people on the team will be IRB certified, so they will understand the importance of maintaining confidentiality and privacy of individuals. And interesting enough, like Rob and I, we talk about, and Rob, you may want to chime in here about the ethical issues about, our digital mental health smartphone app development. We hear in development processes that, features such as, passive monitoring is not something that has been, acceptable by the community of people with a lived experience of a serious mental illness. And it's reminiscent of maybe the earlier days of psychiatry, where there was a monitoring of everything that individuals do while they're involuntarily committed. So an ethical discussion about that, because we want to include the latest and greatest technologies in our programs. However, we're hearing that this won't be acceptable by the community. And Rob and I mean, this is anecdotal, Rob and I are conducting some research in the next month to really understand the ethics of different types of technology features in smartphone applications. Rob, did you have anything to add to that?
Well, I think yes, that we went through the Department of Mental Health IRB, and also that we had to develop consent forms for both the individuals being served and also the peer specialists. So one of the, and as Dr. Fortuna stated, one of the things we're trying to figure out is what happens with the data once it's collected, and even if it's collected and anonymized, what's keeping it from falling into the wrong hands. So it's trying to figure out that quagmire.
Yeah, which has been an interesting conversation as well. Rob and I are working on a PCORI grant where they're looking at 2 different types of chronic disease self-management programs and examining which one works better with people with a lived experience of a serious mental illness. And they're using the PeerTech app, and we were approached by our program officers, and trying to understand the ethics of data sharing. In that, can the data from the individuals who are participants in the study be put in a data repository where others could run data analysis? And so we're coming into this interesting ethical conversations with PCORI on, how do you address human subjects protections for a very vulnerable group and marginalized group of individuals. And so we're kind of early in the stages of that. So I think it's a great question you asked, because we're having issues and questions at all different levels of our research protocol, data collection, and, we're also talking with national folks as well. So it's a great question, and something we need to really consider further. It sounds like a paper. Was that helpful?
Absolutely, thank you.
Thanks for the question.
Yeah, this is great discussion. We have about 5 minutes left. If anybody else has any questions or comments, now's your chance.
Karen, this is Santosh Kumar. Thank you for doing this webinar.
Hey, how you doing?
Doing well.
Thanks for having us.
This area is very, very important of participant disengagement, and all the hard work that researchers do can all go for a toss if the participant is not fully engaged. So I think I'm so glad that you are working on this area and you're sharing your insights.
Oh, thank you so much.
So thank you both you and Rob.
This is Jackie again. I just wanted to say from one researcher to another. University of Illinois Chicago has those answers that you were talking about with IRB. I'm familiar with that. I've done that because I was a researcher for them with peer support. They could definitely, I don't know if you know Judith Cook. She is a researcher.
Yes, I've heard it.
Yes, she could help with those questions and support as well. So I wanted to give you that information. And also, I'm very much interested in being part of the research because I'm familiar with the consent forms in the IRB. So just please let me know.
Oh, that's great. We have, so with the website, we're going to be sending out a newsletter soon. And so we have a Facebook page too, and we add in opportunities for peer support specialists to engage in research. Some of those opportunities have been applying to the American Psychiatric Association to be a stakeholder on a committee that develops the standards for developing digital mental health apps, confidentiality standards. And so we're putting out announcements related to things that may be of interest to the community. So yeah, shoot me an email and we'll definitely we'll stay in touch and we'll share with you our Facebook page too, because we have a lot of really great research happening, not just with me and Rob, but we work with a whole team of peer support specialists across the United States, and now we have some colleagues in Norway we're working with who are very new in developing their peer support services, and so it's very exciting. So yeah, please shoot me an email and we can talk about some additional opportunities.
Thank you.
Okay, I want to give one last chance for questions. If anybody has one, don't be shy. Feel free to jump in.
I'll chime in real quick, Brian. This is Tim Nett from MD2K. Can you speak a little bit about the scale of your app and studies? And more specifically, what are the challenges you face as you kind of continue to grow this and get larger?
Great questions. Currently, with the app, we've done, a pre-post study with 8 individuals, very small. And with that, we were able to write 10 plus manuscripts because we looked at qualitative data, quantitative data, all sorts of stuff. And we were lucky enough to receive National Institutes of Mental Health funding to create another implementation or design of the app. And so we'll be doing a 40-person randomized control trial at that point. And we also have money from the Brain and Behavior Foundation, so we'll be doing a 30-person pre-post pilot with them as well. So that's from the research standpoint, and we'll be applying for an R01 in the next 3 years to examine this as part of my K01 award. Some of the issues in scaling are really interesting because we're getting a lot of contact from peer support agencies and health companies, health insurance companies that incorporate peer support digital services. And so one of the challenges is, working with institutions and preparing the app for potential deployment in the future. And so we have to add in additional features that are, of course, HIPAA compliant, and we'll potentially be doing this in the EU as well, so it needs European compliance too. That was one of the recent challenges, and actually there's a great center with some amazing colleagues up at Dartmouth College that have offered us to assist us in, developing a scalable product that is HIPAA compliant, EU compliant as well, which was probably one of the most important things for us. But now we're not just developing the architecture of the smartphone app, we're developing the architecture of, what it looks like to scale. And so that might be a super admin that adds in other organizations across the country. And that might include a larger data management structure. And so these are some of the challenges, but we've been working through them. And, we're very lucky to be part of this PCORI comparative effectiveness trial because we're deploying to 300 individuals over the next year. So I think we will be able to, we'll definitely figure out more of our implementation challenges at that point as well. So I think the more real world we get, the more challenges we're going to face. What we do have is the acceptability among the peer support specialist community, which has been really hard for others to be able to engage with, especially if they're using a non-recovery approach. So lots of work to do, but really exciting work to be done.
Also, a challenge with scaling it is to make sure that the principles of how we design the app and what the app is based on, because you lose control when it gets scaled up to bigger organizations. But the success of it is the important part of the peer support being coupled with the technology. So it would be a shame if the personal touch got cut out of it as it goes to bigger organizations and bigger platforms.
Yeah.
All right, so I think we are out of time here, but Karen, Rob, I want to again sincerely express our gratitude for both your time and efforts here today, as well as for the impactful work you are doing. Thanks again to everyone who is in attendance for today's webinar. Just a quick reminder that video of this webinar will be available later this week on mHealth Hub, which you'll be able to find at mhealth.md2k.org. And we look forward to seeing you all at our next webinar. Stay tuned for details about that. And thanks again, everyone. And thank you again so much to both of our presenters.